Hi all, I'm Michelle Polen, and today Jasmine Kaur and I are here to present our team's research on the diagnostic reclassification by high-sensitivity cardiac troponin assays. Before presenting today, we want to disclose that our research was partially funded by the Alpha Phi Foundation, UC Davis, Roche Diagnostics, and the NHLBI. Cardiac troponin testing is performed in nearly 1 in 5 emergency department visits in the U.S. Recently, high-sensitivity cardiac troponin assays have been introduced into emergency departments as a diagnostic biomarker to identify myocardial infarction and injury. These precise assays can detect rises in cardiac troponin at lower levels than conventional troponin. While this may allow for more rapid diagnosis and exclusion of myocardial infarction, concerns have been raised that these assays will also result in more diagnoses of myocardial infarction. The objective of this study was to describe the rates of diagnostic reclassification between conventional cardiac troponin I and high-sensitivity cardiac troponin T, and between combined and sex-specific thresholds for high-sensitivity cardiac troponin. We conducted a prospective observational study of emergency department patients at least 18 years old undergoing cardiac troponin testing for any reason. Remnant specimens were run on conventional cardiac troponin I and high-sensitivity cardiac troponin T assays as part of an ongoing laboratory QI project, and results were obtained from the laboratory QI database. Cases with any positive troponin result, above the 99th percentile, underwent physician adjudication using the fourth universal definition of myocardial infarction. Our primary outcome was diagnostic reclassification between the conventional cardiac troponin and the high-sensitivity cardiac troponin assays. The secondary outcome was diagnostic reclassification between universal and sex-specific high-sensitivity cardiac troponin thresholds. Diagnostic reclassification rates were assessed using sample proportions and 95% confidence intervals for binomial data. The slide shown here is looking at our study enrollment. Of the 41,608 adult emergency department encounters during our enrollment period, 1,080 patients met inclusion and were consented. Of these, we excluded 64 patients for the reasons listed in the figure. Overall, 1,016 patients were included in our study analysis.
The median age of our study population was 60 years, and men and women were equally represented. As shown, our diverse study population includes patients with various comorbidities such as CKD on dialysis, heart failure, and coronary artery disease. For our first aim, between the conventional cardiac troponin and high-sensitivity cardiac troponin assays, we found that 0.6% of patients had diagnostic reclassification with regard to MI. Of these 6 patients, 5 were diagnosed with MI using conventional cardiac troponin, but not high-sensitivity cardiac troponin, and 1 was diagnosed with MI using high-sensitivity cardiac troponin, but not conventional cardiac troponin. 16% of patients had diagnostic reclassification with regard to myocardial injury by high-sensitivity cardiac troponin. 154 were reclassified by high-sensitivity cardiac troponin as having myocardial injury, and 12 were reclassified by high-sensitivity cardiac troponin as having no injury. For our second aim, between universal and sex-specific high-sensitivity cardiac troponin thresholds, we found that 0% of patients had diagnostic reclassification with regard to MI. 3.7% of patients had diagnostic reclassification with regard to myocardial injury. Sex-specific thresholds reclassified 13 men as having no myocardial injury and reclassified 25 women as having myocardial injury. This was a single-center study. Therefore, our results may not be generalizable to other patient populations. reviewers adhered to the fourth universal definition of MI, which may not be applied as strictly in clinical practice as it was in this study. Our study depended on patients having remnant samples in the laboratory biobank. 4 patients were excluded for insufficient remnant samples. Overall, this study suggests that when compared to conventional cardiac troponin assays, using high-sensitivity cardiac troponin resulted in no clinically significant change in MI diagnoses. However, there was a substantial increase in myocardial injury diagnoses and patients with elevated cardiac troponin results. Sex-specific thresholds for high-sensitivity cardiac troponin T affected myocardial injury diagnoses and not MI diagnoses. Using these thresholds, there was an increase in myocardial injury diagnoses in women. Hospitals should expect to see more elevated troponin results and an increase in myocardial injury diagnoses when switching to the high-sensitivity cardiac troponin T assay, but no substantial change in the number of MI diagnoses. This study, along with other European studies, failed to show an overdiagnosis in MIs when using the high-sensitivity cardiac troponin assay. To further analyze the impacts of these diagnostic changes in patient care, future studies are necessary. We would like to thank Dr. Bryn Mumma for her mentorship and the rest of our research team for their dedication and hard work. Please feel free to contact us using the email addresses here. We welcome your questions and comments on our research. Thank you for taking the time to listen to our presentation.